Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What would you do if a loved one at home suddenly passed out? Could you perform Cardio Pulmonary Resuscitation, CPR, to save them? Find out more right now. My guest this evening is Amer, an authority on cardiopulmonary resuscitation. Mr. Tobing, welcome to Housecall.
Dr. Doman, thank you very much. I appreciate it.
My pleasure. So briefly tell our viewers about your professional background.
Sure. Well, it started many years ago. When I was 23, I was hired as a firefighter for Montgomery County Fire Rescue. So I spent 23 years in the fire department. The first 10 years, I was a paramedic and a firefighter. And then eventually I continued the firefighting, became an EMT, and eventually retired at the 911 center as a supervisor.
Very nice.
Yes, sir. And in between there, I ended up getting into CPR by chance.
Well, thank you for your service to the
Thank you.
community.
Absolutely, my pleasure.
So what exactly is CPR? What does that stand for?
As you mentioned, CPR is Cardio Pulmonary Resuscitation. And basically what that entails is we're working both on the cardio and the pulmonary aspects of trying to revive somebody.
Meaning heart and lung.
Heart and lung, absolutely. Okay. And basically that is doing compressions and to some degree doing breathing. We find nowadays is that a lot of people aren't doing the breathing, and there are many reasons for that. The compressions have become such a huge aspect. When I first started teaching, we used to do 5 compressions to 1 breath. Mm-hmm. It changed to 15 compressions to 2 breaths, then eventually 30 compressions to 2 breaths, and now they have this idea called hands-only CPR. Yeah, and basically it's all about the compressions.
Now, why do you think the breathing has fallen to the wayside?
What they found basically was a lot of people are really hesitant to really even approach a patient, not to mention have to put their mouth on someone else's mouth. Now, for medical providers, we use barrier devices. For the lay rescuer, the average person, we trained them over the years to basically pinch the nose and breathe into the mouth of the patient, which is, I wouldn't say kind of like a turn off, but can easily kind of turn them away from wanting to help someone. Now with the idea of just hands-only compressions, people are more willing to do those compressions. They're willing to help somebody, and what they say in a lot of our videos, it's better to do something than to do nothing at all. Mm-hmm. So that's the idea. Just it's all. As a matter of fact, even at the 911 center, we tell people to do only compressions, and we actually never tell them to do breathing.
Okay.
Yeah.
Do you think people over the years, their reluctance was also concerned about contracting infections such as HIV?
Absolutely. HIV, hepatitis C, any of those. Putting your mouth on someone, and you can't judge that by just simply looking at it. You know, of course, if they're bleeding or vomit or anything like this, yeah, you would be easily deterred from doing that. But you can't look at someone and just say, oh, I don't think they have some type of communicable disease, I'm going to go ahead and do that. Mm-hmm. But the initiative was really just to get people to take action. And we've seen that almost like 30 to 35% increase in savior rate, specifically here in Montgomery County.
Very nice.
Yeah, absolutely. A lot, absolutely.
So somebody is at home mm-hmm. or out and about, and they suddenly collapse. They're out. They're unresponsive. If indeed they have a cardiac arrest, a life-threatening mm-hmm. Heartbeat or no heartbeat, what is the projected timeline before there is damage and risk to survival?
Absolutely. It's a great question. It's really hard to tell just depending maybe on the age and exactly what's going on. But I think what's more important for people to realize is by the time they realize an emergency, by the time they pick up the phone, by the time they call 911, by the time they go through the initial questions, and it's very important for people to understand those questions. The most important question most people think it's, or the most important piece of information that they think they want to give us is what's going on. And that's not the last, but it's not the most important. And the most important piece of information is the address or the location of the emergency, along with like a specific location, whether it's at a school, in a cafeteria, or in a gym, and so on. So by the time that all happens, and we get to the question of, hey, tell me exactly what's going on or what's the emergency, at least 1 minute has gone by, at least, and maybe longer if the person is having trouble or wanting to get their information out and not listening to our questions. If they tell us, hey, we're doing compressions, or the person's not breathing, unconscious, unresponsive, and they say, hey, we're doing CPR, or we instruct them, we send that call to the dispatcher. By the time the dispatcher sends the call to the units, you're looking at least at 2 to 2.5 minutes. So a lot of times people don't realize that at 2 minutes, and that's how we train our students, is we have them do 2 minutes worth of compressions straight, right? That's one of the aspects of our class, and they realize that this is a lot of work. But what they don't realize is that at that 2 minute mark, fire rescue is just about leaving right then and there.
Yeah.
And our normal response time in Montgomery County is about 5 to 7 minutes. So imagine, let's just take it, I don't want to say average, but let's just take a larger patient. Let's just say someone 210, 220 pounds, and they're maybe 6 foot, 6'2", and the person who's providing the compression is only 5'9" or 5'10".
Yeah.
What does that look like for them?
Yeah.
That's a lot of work.
Yeah.
That's a lot of work. So they have to realize the process from the time the incident starts all the way till the fire department gets there, 5 to 7 minutes, you're looking to 600 compressions continuous. And that's how we instruct people at the 911 center. We just tell them, hey, if you're willing to do it, we're going to instruct you, and you're going to do about 600 compressions per minute. I'm sorry, 600 compressions total.
Now, if somebody witnesses somebody going out, and unfortunately they're alone, what do you advise? Should they call 911 first or initiate CPR first?
Great question. If you would have asked me this 15 years ago, for the adult, we would tell people to go call 911 first and come back because it's usually cardiac in nature.
Right.
And for the infants, it's respiratory in nature.
Right.
But today we find everyone, I would say, 99% of the world has cell phones. And so the idea of being able to call and do compressions almost at the same time works really well, actually, in the end. So we would say call 911, put us on speakerphone, and then we will help you and walk you through that process. I think that most people are not really sure or hoping that there's enough help and how did that process go.
Right.
But we go through the process of, if we're by ourselves, go ahead and call 911, put us on speakerphone. Right. If you have more people, and this is how we train in our classes, is we want one person to take charge. So if you're the doctor, and it doesn't necessarily mean it has to be the doctor or the manager or the supervisor, but if someone decides to take charge, that person might initiate, hey, call 911, hey, you go get a defibrillator, hey, I want you to start compressions, and you're going to be my next person, and so on and so on. And so they create a little bit of...
team leader.
Yeah, team leader, exactly. As we teach, we call it team dynamics. And we see that more like in when you have an office that's really tight-knit, really, and they all can work together. But when you have strangers who come together, it doesn't work as fluid, so to say.
It can be challenging.
Yeah,
Sure.
It is challenging. It is challenging.
What is the data on damage to the brain or the heart if CPR is not initiated promptly? How much time is there?
Yeah. So we normally say that for every minute that goes by without doing compression, 7 to 10% survivability rate goes down. Okay. So that within about 10 minutes, you don't have a patient, really.
Yeah.
And that also goes along with the initiative, hey, start to do something. So a lot of times is, hey, do something and not just stand by. And I can't even begin to tell you how important it is as literally as someone who's local, where we want people to feel comfortable, confident to take that initiative. And if they don't, every second literally counts, every second. So you're looking at within 10 minutes, if no one's done nothing, the likelihood is very meek.
So we've discussed initiating CPR, we've discussed calling 911. Let's say you're in a more challenging place, for example, inside an airport terminal with security. As you well know, there are AEDs nearby. So what exactly is an AED?
So an AED stands for Automated External Defibrillator. And what that basically means is that I know most people will say, oh, it shocks the heart. And some people, and many times we ask this question in classes when we teach, is do you think it's like jump-starting your battery? Like, we see in movies, and a lot of people are, of course, misled by movies that, hey, it's flatline, it's a completely, no rhythm, we're going to jump-start the heart. And in fact, it's actually, the heart is in fibrillation. And by putting this device on...
define fibrillation.
Fibrillation, basically, not to keep it as simple as possible, is like the heart is quivering. Right? And we call that, in our terms, ventricular tachycardia or ventricular fibrillation, or VTAC or VFib. And that heart basically is struggling for oxygen because there's like a block in the heart. And so it starts to go into fibrillation. And what we mean by that is that because the heart is full of electricity, it just starts to fire from different parts. Normally we have what's called an SA node that sits at the top of the heart. It sends that signal.
Right.
And so it becomes a little chaotic, or what we call ectopic. And the defibrillator is designed to reset the heart. Mm-hmm. So if there is no rhythm, then you can't do anything with that. And I think a lot of people are misled by watching movies and TV shows where they look at the screen and says, oh, flatline,
yeah,
right? And then they put it on the defibrillator. And these machines are different, meaning the machines that we train on are, within the $1,000 to $2,000 range. The other ones are in the 40s and 50,000, where they can do pretty much a lot more. They can shock almost anything and anyone at any time. So people need to understand that getting that defibrillator onto the patient as fast as possible is key, because if you miss your opportunity, the VTAC or VFib, as we just mentioned, you've missed your opportunity.
Yeah, because shocking a flat line is
correct.
Is not as productive.
And if people say, "Oh, go get the defibrillator," and they're running through or walking quickly through their building looking to find out where the defibrillator is, and it delays that time, mm-hmm. It can go from what's called normal sinus rhythm, a regular rhythm, from down to VTAC, VFib, and down the flat line. And that VTAC, VFib AEDs are specifically designed to shock those two rhythms, and it won't shock anything else. So the more delay or the longer it is for them to get there could put them from that rhythm down into a flat line.
Do AEDs come with hookup instructions for the lay public?
Yes. My ongoing joke is it's really simple, I should say.
Yeah.
When I say that, it's literally pushing a button. And some of them, when you flip it open, it just starts talking to you. Mm-hmm. So if one of the things we try to do in our class is to keep things as simple as possible. Mm-hmm. So most of the times for CPR, we tell people it's all about the compressions. Mm-hmm. For the defibrillator is go get the AED, turn it on, and listen. Mm-hmm. All right, so I'm just using my finger, go get the AED, turn it on, and listen. And once that AED arrives, it's like your on-site coach. It tells you everything that you need to do. From even if you haven't exposed the chest, even if you haven't checked responsiveness, even if you haven't called 911, it ensures that, hey, make sure you've called 911, make sure you've done all these steps, and then you just follow it. Place the pads on the chest. All right, I'm not sure how much detail you want me to go, but I can.
You're doing fine.
Yeah. Well, I just want to make sure everyone understands that the pads have pictures. Mm-hmm. Some of the pads, AEDs, the words are minimal. Mm-hmm. So basically put the pad top one on top right, bottom left. The idea really is that as long as there's a heart somewhere between the defibrillator, mm-hmm. Between the pads, that's what we want. We want it to be able to try to read that and see what happens, and that's how it shocks and resets the heart. There are precautionary measures that you need to have. You want to make sure that the chest is completely bare. Any jewelry or anything like this, move it so it doesn't arc and cause any burn marks. Sometimes with hairy chest, you might have to shave off the hair. All these things, make sure the pads are nice and tight. But most importantly, realize that you want to pay attention, because these defibrillators will shock starting anywhere from 125 joules, and defibrillators that the fire department carries are up to 360 joules.
Wow.
And that's a lot. That is a tremendous amount.
Now, I want you to hold a thought about AED.
Absolutely.
We're going to pause briefly for a public service announcement. More with Amer Tobing, an authority on CPR, in a moment. We'll be right back. We're back with Mr. Amer Tobing, an authority on cardio pulmonary resuscitation. Mr. Tobing, when we were chatting before the break, we were discussing automatic external defibrillators, AED. Many of our viewers may be nervous about having the responsibility to make the decision about whether or not the defibrillator should fire. Is it true that they have that responsibility, or is it already done for them?
Yeah, it's a great question. Many, especially companies who feel like, I don't really want to get one because it's a liability, it's actually the opposite. It's a liability not to have one. AEDs are specifically designed, as I mentioned earlier, to shock specifically VTAC and VFib. it's not up to the person. And a lot of times in classes, it always happens where people are like, oh, I'm going to use the AD on you, I'm going to push it, and it just won't work that way.
Yeah.
Literally, if we have a
show us what it looks like.
We have, this is one of the ADs. We're a distributor for many different ADs. This is the Zoll grade AD, but you can't just simply open this up, place it on someone's chest and say, hey, check it out, and then
push
a button. It just doesn't work that way.
Yeah.
They have to be in that rhythm. Yeah. So a defibrillator definitely is a life-saving device. It's not like a weapon. It's not like the taser guns.
Right.
As a matter of fact, the taser guns that the police use are very low. They're like 0.36 to 0.5 joules.
Yeah.
And these are, as I mentioned earlier, a lot higher.
Right.
So throw it on there. If it works, if it tells you to push, push. Meaning push the button.
Yeah.
If it doesn't, it won't.
Right.
And your job, just so you know, is just put it onto the patient and follow the instructions if it's required. And when I say that, once it's on, never take the pads off until when I say we, meaning the fire department shows up.
Right.
Okay. So that's just, there's so many different AEDs out there. I think what people really need to know is to know where they are. I have many clients who have, one specific who used to see a box, a defibrillator right outside the elevator.
Yeah.
And we were sitting in the middle of class and he said, oh, that's what that box is. And he had no idea, and he's been in that building for 10 years.
Yeah.
So need to know where it is, grab it, get it to the patient as fast as possible.
Let's go back to CPR then. First of all, a fundamental question. How does it work?
Very great question. So CPR basically, as we mentioned, is the idea of compressing someone's chest. If you do mind if I...
Please.
I'm going to show you here. So I brought a mannequin with me, and I just want to make sure everyone understands. This is by no means the average size person, but we use these mannequins, and all the mannequins now starting in 2019 have feedback devices, meaning they have a clicker inside, they have a light that shows you're doing the compressions correctly. And specifically talking about what's called hands-only CPR, or just compressions, is that you want to find the center of the chest, and we don't focus too much on it. The idea is start compressing. And as I mentioned earlier at the 911 center, when we give those instructions to someone to do compressions, we're not really sure if they're in the exact same place. We ask them, are they willing to do compressions? They say yes. Are they on a flat, hard surface? They said yes. Okay, put one heel of one hand in the center of the chest. Now, this is a part of our training. We have breakaway shirts, so it's easy to find the center of the chest. But what happens when it's the winter and you have, Under Armour clothing and sweatshirts and so on? You can't simply just rip the shirt off. So that being said, one of the tricks we kind of use is center of the chest, hand near the armpit of the patient, slide up, heel of the hand. You're going to lock your arm, and just because this table's a little high, you're going to lock it so it's straight, and then the other one's right on top. Most important, the bottom one. So some people might do this, some people might do this, but as long as that heel of the hand is there, lock it in, and you're going to compress. And the beauty of hands-only CPR is, as you're compressing on the chest, you're moving the oxygenated blood through the body. Also, every time you press on the chest, what's happening here? Air is going out. And when you release, what happens? Air goes right back in.
So you're helping them breathe, but indirectly.
Yeah. There's actually a really interesting story. In Minnesota, they had they did compressions on a gentleman who collapsed for 96 minutes. If anyone looks up 96 minutes Minnesota CPR, they shocked him 12 times, but mostly they didn't breathe. All they did was compressions and a defibrillator. Yeah. And if that's what you have, and you've done a tremendous amount for that person, So that's a little bit for that. And also, just so you know, we have infants as well. The infants are just a little different. You would use 2 fingers. Right. All right. And I know because of the innocence of the child or the infant, people are still going to want to breathe, and that's totally fine. We're not going to say don't breathe at all, but if it's just going to deter you from helping someone, then forget the breathing and do the compressions. Sure. Okay.
Now, the CPR, you think it works because the heart is compressed between your compressions and the spine, and that's where the blood flow is restored?
Absolutely. So we're certified through different organizations, American Heart Association, American Safety Health Institute, and Red Cross. They all have numbers, 2 to 2.4 inches, or 5 centimeters, and the numbers are great, and it gives a little bit of a standard. It gives you an idea of, hey, I get an idea, this is how much 2.4 inches. But I think personally, because I've done this in real life, do you really actually calculate, hey, this is 2.4 inches. And my thing when we're teaching, we're training people, is that if you see someone that's a lot larger than you, and seeing someone laying down is different than them standing. If you look at someone and they're, 200 and some odd pounds, you've got a lot of work in front of you.
Yeah.
And I would tell people, don't be shy. Can you break ribs? Can you puncture lungs? Can you separate the entire sternum from the rest of the body? It's possible. But that is all secondary to someone not breathing. So go ahead and do those compressions. Obviously, the smaller the patient, don't push as hard. You can, for a child, which we say is from the age of 1 to puberty, you can use 1 or 2 hands, and for the infant, you would use 2 fingers. But if you have a large infant, like one of our clients said, well, that infant's not a Texas baby, right? It's just they basically go ahead and use the heel of your hand. Go for it. Don't be shy. But because we want those compressions really to help move that blood through the body, push that air, and allow the air to come back into the lungs. So.
Now, if the event occurs in a place that is well supported, in other words, there's somebody there to step in for CPR, use a cell phone for speaker, reporting to 911, and let's say there's also an AED nearby. Those are ideal circumstances. Yeah. Let's take another extreme, though. You're off in a remote area. Let's say you're hiking or something in Shenandoah National Park, and somebody has a cardiac arrest. You send somebody who's with you to go to the nearest forest
safety center,
station to get some help. But how long can you perform CPR before you have to throw in the towel?
That's a great question. I think that we used to focus on that a little bit, where hey, there are several reasons why you would stop. For example, if the scene becomes unsafe, you become exhausted, someone else shows up, the defibrillator, you're putting that on. The idea is that you do what you can. This incident in Minnesota, there were 20 some odd people there, and they rotated. And what they called, each individual went to the point of exhaustion. We normally tell people that, hey, do at least 2 minutes as a maximum, because the defibrillators are designed to shock every 2 minutes. Okay. But you're to do what you can, keep pushing. If you feel like you need to take a break, and I'm not giving some type of ruling on it, but you might have to take a break, and then you might have to restart again. But if you can get other people to help, that's the idea. Make it a group, if you will, a group effort to bring this person, just like in Minnesota, honestly. But just keep pushing. I know it sounds a little, real simple, but that's what it comes down to.
So there's no arbitrary time to say this is not happening and throw in the towel.
There are some signs and symptoms that we use at the 911 center. Things that are like, blue or cold and stiff, decapitation, these type of things.
Right.
Otherwise, if you eventually touch the patient, hey, are you okay? Are you okay? And that's one of the processes, right? We talk about, and I didn't make it clear earlier, is that when you walk up, you're to assess the scene. So all these begin with the letter C, pretty much. Check the scene. Check responsiveness. Hey, doctor, are you okay? Are you okay? They don't respond. Call 911. Get an AED. And then check and scan the chest for 5 or 10 seconds, and then you start doing the compressions. But once you touch them, from what I understand, it's a liability. You basically have engaged with that patient, and if you walk away, you could be negligent, right? Yeah.
Well, I certainly agree, and I can tell you from firsthand experience, very often these events occur in the least opportune times.
That's correct.
For example, as I told you previously, I did CPR in a plane.
Oh, that's right.
At 35,000 feet.
Yes.
And that raises all kinds of challenging things, including my being mic'd into a ER at the nearest city for an emergency landing. Yeah.
Once again, I think it's about, our training is really about getting people to feel comfortable and confident, to just take initiative and not step back and say, I'm not really sure. Do something.
Sure.
Do something, so.
Let's shift gears briefly then to other emergencies you might deal with, a lot of which is also relevant to CPR. Let's go to drowning. Okay. Somebody's found in a pool. Yep. They're pulled out. They're unresponsive. Yep. How do you assess them, and what do you do? Great
question. So now this training, when I say this training, the statistics I'm going to give you is from a long time ago, that when we started this CPR, we find that most of the drownings are what considered wet drownings versus dry drownings, where the water gets into the lungs versus it doesn't get into the lungs. And the answer is actually fairly simple. It doesn't matter actually if it's a drowning, a heart attack, diabetes, dehydration. If you go through the process and find that the patient's unresponsive, just do the compressions. I know that a lot of people, or I should say, when you do those compressions, water might be coming out and going this way and that way. Don't worry about that. That's all secondary. I think that if you focus on the reason why someone collapsed, you might get into the whole, well, what should we do? Should we do this and should we do that? Go back to the fundamentals. Check the scene, check responsive, call 911, get it AED, check for 5 to 10 seconds, and then start doing compressions. So drowning is similar to anything else, all secondary. Compressions are number one. You're going to hear me say that a lot.
Good. Now, why is it some people are so-called dry drownings and others are wet?
What happens is that from our training from many years ago is when they drown, and then that epiglottis will shut, and so that water is caught above and not below that epiglottis. Things may have changed, but generally speaking, that's the idea.
And they don't go into the lungs.
Yeah, they don't go into the lungs.
And if somebody is a wet drowning and during your CPR water, frothy stuff is coming up, do you stop CPR momentarily, lay them on the side so it can drain out and then resume, or just keep going?
Keep going. That's it. Don't worry about that. You just keep on going. Okay. We don't. As the second that you stop doing compressions, the second the blood stops flowing through the heart.
Do you think in a wet drowning or dry drowning situation, if you, of course, doing CPR, call 911, and then have an AED nearby, do you think applying an AED has some risk if the area is wet?
We basically say as long as you're not in standing water, you're going to be moist anyways. Like, I shouldn't say anyways. When you have someone who has chest pains, or heart attack, I should say, heart attacks can present with nausea, color change, and some of that's so they're going to be sweating, right?
Yeah.
It's going to have some perfusion. So you can wipe it down quickly, throw the pads on there. They're very sticky. Throw it on there and just follow those instructions. As long as you're not sitting in wet ground. All the AEDs have different what's called IP ratings, and which was for like dust and moisture, specifically for the AED. But also, you don't want to deter or you don't want to stop using an AED in this situation. Just go all the way through with it.
Very good.
Yeah.
Now, we are out of time, so if our viewers have any questions, how can they reach you?
They can reach us at either liferescuetraining.com or our number, 301-327-2525. We have a new device coming out. I'd love for them to check it out. It's called CPRtracker.com.
Okay.
And for them to look at it, it's going to basically help them go through the compressions and keep them on track. And just all they got to do is push a little button and follow it.
Thanks for the information.
Absolutely.
My thanks to Amer Tobin for a superb interview on CPR. My thanks to my team here at the station, and my thanks to you, the viewer, for inviting us into your home. Tell us how we're doing. You can reach us at my practice website, montgomerygastro.com. As for our next show, it's going to be very interesting. Dr. Eduardo Sotomayor, a director at the Cancer Center at George Washington University Medical Center, will be giving us an update on all the latest diagnostic and therapeutic approaches to cancer. It's going to be a terrific show. See you then next time for another edition of Housecall. Good evening.